and welcome to today's Public Health Ontario Microbiology Rounds presentation on COVID-19 vaccination in dialysis patients. My name is Vanessa Tran, and I'm a clinical microbiologist at PHO, and I have the pleasure of moderating today's session. Before we begin today's presentation, I'll just mention a few housekeeping items. Firstly, the chat pod has been disabled to limit any distractions during the presentation, so please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as moderator of this session, I do not have any potential conflicts of interest to declare. It is now my absolute pleasure to introduce the speakers for today's presentation, Dr. Michelle Haldunowicz and Dr. Kevin Yao. Dr. Haldunowicz is a nephrologist who received her medical degree at the University of Alberta, completed her internal medicine training at the University of Toronto, and her critical care and nephrology fellowships at Stanford University Medical Center. Michelle is the physician-in-chief at Sunnybrook Health Sciences Center and the clinical trials director at the Toronto glomerulonephritis. I knew I was going to have a hard time with that one. Clinic and Registry, and the Ontario Renal Network medical lead for the, I'm just going to say, GN and specialty clinics. Dr. Kevin Yao graduated from medical school at the University of Toronto, completed his internal medicine training at Western University and his nephrology fellowship at the University of Toronto. He is currently completing a cardiorenal clinical fellowship and a master's in clinical epidemiology and healthcare research at the University of Toronto. We are both very excited for both of our speakers today, and I will hand it over to them to start the talk.
Thank you so much, Vanessa, and thank you to Public Health Ontario for inviting us here today. I think it's safe to say, as an expert in what it is glomerulonephritis and pregnancy and kidney disease, and we go into the realm of infectious diseases, both me and Dr. Yao are out of our wheelhouse. But COVID is really important to our patient population, and I'm hoping today will sort of, enlighten you as to why this is such a critical thing in the kidney population. So we are funded, and these are our disclosures. The work that we're doing at Sunnybrook and at the University of British Columbia, as well as across Ontario, is funded by the COVID Immunity Task Force, and we're very grateful to the task force for seeing the importance of understanding COVID in the renal population. We also have a grant from the Aureopolis Baxter University of Toronto Division of Nephrology, which was the seed money that started all of our projects. And quite honestly, to understand what's going on with COVID-19 vaccination and safety in the dialysis population and the CKD population, as you can see, it takes a village. These are our collaborators. We have multiple collaborators throughout the GTA in Ontario, through BC, and we're working both with the Ontario Renal Network, ICSS, BC Renal, the CanSolve, which is our translational patient arm, and of course the Public Health Agency of Canada. And overall, our COVID studies aim to better understand the humoral and cellular immunity of vaccination in our population. We have large epidemiological studies going on to understand really the population level effectiveness of vaccine. And of course, we want to understand vaccine safety in our population with renal disease. So the overall objectives that we hope to get forward today are first to describe the impact of COVID-19 on the dialysis population primarily, understand how antibody response is assessed post-vaccination, describe vaccine effectiveness in the dialysis population, and also discuss where we are today, which is really now approaching booster shots within our at-risk populations. So just so we know that we're speaking to a public health audience, but just so you know, what is chronic kidney disease? And, this is just a classic thing that tells you that it comes in very, very many stages. It tells you that our top causes, are diabetes, hypertension, and glomerulonephritis. And 23,000 patients are on chronic dialysis in Canada. But chronic kidney disease is a massive epidemic that doesn't get the appropriate attention. And just today, the International Society of Nephrology actually sent out a challenge. We all have to run 850 miles so that we can match the 850 million people around the globe that are suffering with chronic kidney disease. Now, there is two types of dialysis, and we're going to be talking a lot about this in dialysis population, so it's probably good to just give you a sense. There's hemodialysis, which is wherein we take your blood out of you, clean it, and put it back in. And then there's peritoneal dialysis, which infuses fluids into your abdomen and pulls out toxins in that regard. Hemodialysis can be done in center, or it can be done at home as well, whereas peritoneal dialysis is a home-based modality. So the first thing to understand about the dialysis population is that the risk of getting COVID is remarkably higher if you are a dialysis patient. This is a study that was published in CMAG in 2021, and it's from Ontario. And it says, and this was in the first and the second wave, and it noted that 1.5% of the hemodialysis population of Ontario contracted COVID infection in the first 5 months of 2020. And that's at a rate of 5 times the Ontario population. 264 in hemodialysis compared to 27 Ontario population per 100,000. So again, the rates were really quite high among the hemodialysis population. And some of the risk factors were in-center versus home dialysis, and we'll explain to you in the next number of slides why that's such a high risk. Of course, we also saw long-term care residents, and many of our dialysis patients actually do live in long-term care. We have high volumes of dialysis patients in the GTA. Non-Caucasian patients, so anybody from a more marginalized community is higher risk, and lower income quartiles. These are things that came out in other studies as well. And why might be the fact that dialysis patients are so at risk, therefore, to get infected? Well, they actually have a lot more exposure to the public, if you will. There's been outbreaks in dialysis units, and this was a really nice quote that came out from one of the infectious disease doctors at St. Michael's Hospital. Says, we're telling people to stay home, but dialysis patients can't stay home. They have mandatory treatment at least 3 times per week, where they interact with many members of the healthcare profession. There's a variety of transportation issues, and most of our patients come here by public transport, and they're really exposed to a lot of different healthcare providers, and that places them at risk. So outbreaks do occur in dialysis units, and they've happened throughout Ontario. This one was published, though. This is from St. Mike's Hospital. It's an outbreak in urban hemodialysis unit, and it affected 4.6 of their patients, 12% of their staff, and actually was a really, really complicated outbreak. And then the next slide will show you why that is. So this is sort of what can happen in a dialysis unit. There were actually 2 simultaneous index cases at the same time. One was a staff, and that staff went on to infect multiple other staff and patients. Those patients went to infect other patients who share their pod with them. Dialysis patients also congregate at places like the ice machine, in elevators to get to their dialysis. There's a variety of ways that they come in contact with each other to actually contract COVID. But the dialysis patient that brought it into the unit actually brought it in on Wheel-Trans. So again, a very significant interaction that our patients have is with public transport that brings them into the dialysis unit. And by Sanger sequencing, they did confirm that there were probably more than one set. That wasn't all nosocomial. It was brought in from the community and by 2 separate individuals that then spread pretty rampantly through the dialysis unit. And it really highlights how easily our patients can be exposed to COVID-19. And it wasn't easy for them to manage it either. So this just shows what went into managing that outbreak. Once they declared the outbreak, they started just trying to put patients in certain pods and cohorting the positive patients. As it spread beyond that, they ended up sort of cohorting the entire dialysis unit. And then they had to start surveillance swabs of staff, of patients. And it took quite a number of days and weeks to really declare this outbreak over. So it was a very stressful time for St. Michael's Hospital. So here is our first polling question. What do you believe the mortality from COVID-19 is in the dialysis population? 5 to 7.5%, 10 to 15%, 25 to 30%, or 40 to 45%? Okay. So in fact, I would say the good number of you are actually correct. The likelihood of mortality is 25 to 30%. So this is another Ontario study that looked at COVID-19 in long-term dialysis patients. And what they actually found that not only was this has a high mortality with a case fatality rate of 28.3%, but it's also very morbid. So 62% of the patients that contracted in dialysis actually did need hospitalization. So patients do become very sick with COVID-19. And just anecdotally at Sunnybrook, I could tell you that there are patients that were admitted from the very first wave that have not made their way out of rehabilitation facilities and so forth because they were so affected by COVID-19. This is data from the US that shows us it's not just a Canadian phenomenon. And in the United States, the number of patients that enter dialysis has been going up yearly for decades. But the red line here tells us when COVID-19 started. And this was actually the first time in history, in fact, that the US dialysis population dropped off. And that's because patients were dying of COVID-19 in dialysis units. And this is a study, again, that was done in Ontario, just to get a sense of what was the prevalence of it, because people were always worried about asymptomatic spread and so forth among dialysis patients. But in fact, what this study actually showed us that it's quite unlikely for a dialysis patient, not impossible, of course, but quite unlikely for them to develop this infection and be asymptomatic. And that speaks again that they have a higher morbidity when they do get COVID-19. And finally, we know this already from our previous studies in dialysis that our patients don't mount great immune responses to vaccination. A lot of our data comes from hepatitis B, but we know that when we vaccinate our patients for hepatitis, not only do we use a higher dose, but we often have to use repeated series. And even after repeated series of hepatitis B vaccination, only about 60% of our dialysis patients ever mount immunity. So not only can they more likely get infected, not only is COVID is more morbid and causes higher mortality, we know our patient population responds less well to vaccination. And all this set the stage for our work in studying the COVID-19 pandemic and the vaccination. And I'm now going to hand over to Kevin.
Thanks very much, Dr. Klodanowicz. So, as we mentioned, we were worried that, given that history of poor response to other vaccines, we weren't sure how the COVID-19 vaccines would fare in our CKD and dialysis patient population. And so the large studies that led to the approval of both the Moderna and the Pfizer vaccines didn't include a lot of patients who had kidney disease. So for the Moderna vaccine, they didn't even report people who had kidney disease or dialysis. And for the Pfizer vaccine, they had 256 patients out of about 40,000 who had renal disease. And so that really led us to want to investigate further what the immune response was in our dialysis population. And so what we've been doing almost over the past year is regularly taking serologic assessments in our dialysis patients. They come frequently, our in-center dialysis patients, to receive treatment. And so it's been an opportunity for us to do regular sampling at different intervals. So we have blood work on them before their first dose, before their second dose, and we did it monthly for 6 months, and we're continuing to sample them, and we're almost at a year out after vaccination. And this has given us a lot of information to understand the immune response. So what antibodies have we been testing? So SARS-CoV-2, of course, is the virus that causes COVID-19. And the main target of the vaccines, mRNA vaccines, is the spike protein, which protrudes from the virus. And within the spike protein, we measure the spike protein itself. There's also a receptor binding domain, which is called the RBD, and that's particularly important for viral neutralization. So we've been measuring both the spike protein and the RBD as measures of vaccination. We also measure a nucleocapsid protein, and this isn't targeted by the COVID-19 vaccines that are available. And so if this turns positive, it's only because someone had a natural COVID-19 infection. So it's a good indication of exposure to infection. We've been doing these at a lab at Mount Sinai Hospital, and they report these as ratios to a curve that they have, and we also can convert them to standard units that are used internationally. And what we consider positive just means you have detectable antibodies. So that's what we refer to as seroconversion. And we also make a comparison to convalescent serum, which is blood from people who had COVID-19 before. And there's a cohort of patients, 211, who we know their antibody levels after they had COVID-19. And this is actually the group of patients, the convalescent patients. And you can see that actually they pretty much mostly had fairly consistent antibody responses for the spike and the RBD after they had infection. And so the rationale for this comparison is that once you get vaccinated, you probably should make antibodies to this level to have a robust immune response, although it's not a perfect measure and we don't know the exact level that you need to be protected. And this is just an example of what it looks like in our dialysis patients. So we actually had their results before they got their vaccine and after they had their vaccine. And you can see before their vaccine, the y-axis is the spike antibody, the x-axis is the nucleocapsid, which only turns positive when you have infection, and then the degree of red is the RBD. So most people really had no antibodies we expect before vaccination. We had some people who had COVID-19 before who had antibodies. And then after you get vaccinated, the majority of the patients land up in this box where they have spike in RBD, but no nucleocapsid. And then we have a number of patients who were exposed to COVID-19 itself and have also positive antinucleocapsid antibody. And the antibody tests are quite sensitive and quite specific. The antinucleocapsid does have some cross-reactivity with seasonal viruses. So there's, and it can fade a little bit more over time, but overall they've been very useful. So we've been doing a lot of blood work in our dialysis patients. This doesn't always work for some of our other patients who really would prefer to stay home and not have a hospital exposure to come for blood work. So we've been using dry blood spot, and other studies have been using this as well to get at people at home who can just prick their finger, blot a drop of blood on a card and mail it back. And their antibodies can be tested this way. Sort of the distribution of the antibody results are a little bit different for the dry blood spot compared to blood, but you can still make a good comparison there. So that's how we've been trying to get at some of our chronic kidney disease patients who are mostly at home. So one of the first studies that we did was looking at the Pfizer antibody response after 1 or 2 doses of vaccine. Back about a year ago, more than a year ago now, when the vaccines were first released, there was a limited supply and Ontario was really prioritizing people to get their first dose of vaccine, and therefore people were having their second dose delayed to allow everyone to get that first dose. And the same was happening in our dialysis patients. So we had a group of patients at Sunnybrook who had 2 doses because they got in before that policy was enacted. And then there was a group who only got 1 dose after that policy went into place. So we overall had 142 patients. They were pretty similar overall. A handful had prior COVID-19, but were otherwise had pretty similar characteristics. And we checked their antibodies, their spike, RBD, and nucleocapsid at these time points. So for the people who got 1 dose, we checked their antibodies before they got the vaccine, their first dose of vaccine, and then we checked their antibodies 4 weeks later. And in the people who got 2 doses, we checked their antibodies right before they got their second dose because they were kind of ahead of the curve. So that's the first time we could get their antibodies. And then we checked it 1 week and 2 weeks after that second dose. We also had some healthcare workers who were our healthy controls, and the healthcare workers both had 2 doses of Pfizer. And so we measured their antibodies 4 to 7 weeks after they got their vaccine. And so this is what we found. I'll take you through this plot here. So the top shows the spike antibody and the bottom shows the RBD antibody, and they overall show similar trends. So the antibody levels are plotted here as relative ratios. And this seroconversion in the light blue just means you have the detectable antibody. And that convalescent level is what we've described before as what we sort of defined as being a robust antibody response. And we show the percentage in each group who meet that convalescent level. So pre-dose 1, people don't really have antibodies unless they've been exposed to COVID-19. So as you expect, there's only a handful who had antibodies. And then we found that these 2 groups are essentially very similar, that after the effect of 1 dose, only 23 to 25% of patients had reached that convalescent level after 4 weeks after the first dose of vaccine. And then once people get that second dose, that starts to go up to 57% 1 week after, 72% 2 weeks after the second dose, but still not as good as our healthy controls, where their antibody levels are clearly nicely clustered much higher. 100% of them have antibodies above this convalescent level. And we essentially see a very similar thing for the RBD, which we think actually correlates better with neutralization. And it's just the amount reaching this convalescent level was lower. It was only 6 to 13% after one dose. And it went up further after the second dose. And again, our healthy controls, 100% of them were above that convalescent level. So we concluded from this study that really the antibody response in our dialysis patients wasn't great after one dose. And this ended up leading to prioritization of them for the second dose. And so they didn't wait as long to receive the second dose, and they received it mostly close to what is recommended, the 3-week interval for the Pfizer vaccine. As mentioned, we also checked the nucleocapsid, and we were a bit surprised that we found a number of people actually who we didn't know had COVID-19 did actually have some exposure to asymptomatic COVID-19. Of course, symptoms are probably milder once you receive infection, so some of them might fly under the radar that way. And when we did ask all our patients about their side effects after the vaccine, and so if anyone had a side effect, it did predict whether you had seroconversion for the RBD antibody, although it didn't necessarily predict reaching the convalescent level. But it kind of matches what we think clinically, that if you have, some sort of reaction after the vaccine, that hopefully you're mounting an antibody response. And our study is one of a number of studies across the world that have looked at this response in dialysis patients. Our study is actually plotted here and here. And people have found very similar things, that dialysis patients don't respond well to one dose of vaccine, but after 2 doses, the rate of responders, although the definition is sort of variable, is reasonable. It's upwards of 80% in dialysis patients, although the antibody levels are clearly lower than healthy people. One question that comes up often is, how useful are actually measuring antibodies? We do it because it's obviously the simplest thing that we can do. We only need blood, and you can easily test for antibodies. And they do seem to be helpful. This is just one of a number of studies that have shown that. So this study showed healthcare workers who got 2 doses of vaccine but had breakthrough COVID-19 infections. And when they were matched to about 5 healthy controls, they had lower antibody levels for spike and lower neutralizing antibody level titers. And so it overall seems to support that at least the degree of antibody level has some correlation from protection from symptomatic COVID-19 infections or breakthrough infections, although an exact cutoff is still kind of elusive. As we've mentioned, for our dialysis patients, we've been able to do quite a bit of assessments about their serology because they come so often for treatment, and we've been able to get a good idea of what their antibody response looks like over time. Most people wouldn't be able to get blood work so often, but we were able to do it almost weekly for a while, up to 6 to 7 weeks, then we did it monthly. And we kind of broke up our patients into different groups in the way they responded to vaccination. So on the first 3 groups had a better response overall. After their second dose, their antibody levels nicely go up, but they're still declining over time, sort of at different rates. And then on the right 2, the light blue and the purple plots, the blue patients really never had any response and didn't look like they were ever going to respond after vaccination. And the patients in purple, they had some degree, they seroconverted at least, but a lot of them by 13 weeks, their antibody response was fading, and a number of them became seronegative. And so these are the patients that we're more concerned about. With vaccination rolling out so quickly, people kind of received whatever vaccine was available, and it was encouraged that, regardless of vaccine type, you should get vaccinated to receive protection. But there wasn't a lot of information on, is there a difference between the vaccines? And so we were interested in looking at this. At Sunnybrook, we gave all Pfizer out just because of that was the vaccine that was available. At one of our other hospitals, UHN Moderna was the vaccine that was given out. And in dialysis units, it's often done on a dialysis unit-wide basis. So everybody in the entire unit basically gets the same kind of vaccine, just because it's actually logistically easier. But we ended up comparing 2 groups of patients from these 2 hospitals to compare their antibody response. And this is what we found. So we compared Moderna versus Pfizer in our hemodialysis patients. And I'll take you through this here again. So the left is the spike antibody, the middle one is the RBD, and the right one is the nucleocapsid, which just shows people who had exposure to COVID-19. And we compared Moderna versus Pfizer at 6 to 7 weeks and 12 weeks after. And similarly, we've again shown where you have seroconversion, where you have detectable antibody and the convalescent level. What you'll see is that immediately recognized is that the Moderna patients had higher antibody levels at all time points compared to the Pfizer patients. And really people who receive Pfizer, their antibody levels are kind of more all over the place. They kind of cluster all the way up and down, and their antibody levels, when you get to 12 weeks, they're kind of starting to fall. While patients who receive Moderna, the antibody levels seem to be better maintained. And then anecdotally in this group, the only people who had COVID-19 infections after the 2 doses were in the Pfizer group. There were 3 patients who had COVID-19. 2 of them were pretty early after the infection. One was like 70 days after. Hard to draw, firm conclusions from that, but it does make you wonder if the antibody response, has any correlation with vaccine effectiveness overall, and especially in a patient population that's more vulnerable and doesn't mount as strong of an immune response as the healthy population. We did some adjustment for, different potential confounders, and we still found the same thing. Your odds of, attaining the convalescent level of spike was 10 times higher with Moderna, and it was 6 times higher for the RBD with Moderna in comparison to Pfizer. And even when we look by age, you actually do see, interestingly, that, as you get older, your antibody levels generally seem to be lower. And it again just shows that on the left is Moderna, on the right is Pfizer. The Pfizer patients really had a much greater spread in terms of what their antibody response was after vaccination. And, we wondered, are we the only people seeing this? And no, it actually seems to be a consistent finding at different places. And so this is a healthcare worker study in Belgium that included 1,600 healthcare workers. And they also found that Moderna seems to have greater immunogenicity in comparison to Pfizer when they measure that RBD antibody 6 to 10 weeks after the second dose. And when you look at hemodialysis patients, this is another nice study from the United States where they also found a similar thing. Moderna seems to elicit a greater antibody response. So blue is kind of in this picture is greater antibody response. The more red it is, the lower the antibody response. And people who received Moderna had greater antibody response. And they also compared dialysis patients to controls. And you can see there's a lot more blue for the controls. And so overall, the antibody levels were much higher in controls in comparison to dialysis patients. So it seems to be a fairly consistent finding. And in this study, they also were able to evaluate cellular immunity, which has been more challenging to measure. But on the y-axis is the quantiferon, which is the cellular immunity assessment. And on the y-axis is the spike antibodies. And you can see that there is a correlation between the antibody response and the cellular immunity response. The blue dots are dialysis patients, and you'll see that the red dots are the healthy volunteers. And clearly, the healthy volunteers have both a better cellular and humoral response in comparison to dialysis patients. So it's a big question that comes up. Why are we seeing this difference in immunogenicity by vaccines? Why does Moderna have a higher antibody response in comparison to Pfizer? And one of the main speculations is that it's a matter of dose. The Moderna dose is 100 micrograms. The Pfizer dose is 30 micrograms. And these doses were arrived at in studies for dose finding studies, early dose finding studies, to balance sort of systemic reactions and immunogenicity. That might be one reason. Another reason that's been suggested is, the priming period between the first and second dose is a little longer for Moderna. It's 4 weeks in comparison to 3 weeks for Pfizer. And we are starting to learn that the longer you wait between the first and the second dose, the better your antibody response, although it's hard to know that 1 week makes all that difference there. There may be other factors, different epitopes targeted by the different vaccines, but we're not entirely sure at this point. We've also, of course, been wondering about variants of concern. The Delta variant is the main variant floating in Canada right now. And of course, we have the specter of Omicron on us right now that we don't know a lot about. This is a a paper by our colleagues who have been looking at a similar vulnerable patient population. They've been looking at long-term care residents, and they looked at neutralization against variants of concern, the orange being wild type and different variants of concern plotted on the right. And overall, different variants of concern require higher levels of antibody titers to neutralize, especially the B117 variant, which fortunately actually isn't floating around very much right now, required quite a high level of antibody to neutralize. And then there's just sort of Omicron neutralization data starting to float on Twitter, but we don't have the full story on that yet. And so that is one concern that arises as the variants of concern emerge. And so how does this antibody response translate into actual vaccine effectiveness in this patient population? We have looked at this at a provincial level in Ontario. We have data on all our dialysis patients in Ontario, and we did an observational cohort study in this patient population, and we classified people by whether they had been vaccinated, received 1 dose or 2 doses of vaccine. And so in this plot, the orange is the first dose of vaccine, and the green plots are the second dose of vaccine. And you'll see that the second dose of vaccine was really when the third wave of COVID-19 was sort of just starting to fall, which is plotted in gray in the background. And we use this information to try to calculate vaccine effectiveness from the mRNA vaccines. So what did people receive in Ontario who are on dialysis? As I said, most vaccination is done on a dialysis unit-wide basis. And actually, most people ended up receiving Pfizer. 74% got Pfizer, 25% got Moderna, and then just a handful got AstraZeneca, likely from their pharmacy. And so when we classify people in this time period as being unvaccinated, having 1 dose of vaccine or 2 doses of vaccine, we were able to sort of figure out their infection rate with SARS-CoV-2, hospitalizations, and mortality. And it's obviously clear when you sort of adjust by the 100,000 per 100,000 days that infection rate, hospitalization, and mortality are going down once you get 1 dose and 2 doses of vaccine. We did an adjusted analysis to try to actually calculate the vaccine effectiveness numbers that we care about. And so when we do an adjusted analysis, accounting for this whole host of factors at the bottom that could potentially confound our results, what we found is that for actual COVID-19 infections, 1 dose had an adjusted vaccine effectiveness of 41%. And then for severe outcomes or hospitalizations, effectiveness was 48 to 49%. And for mortality, it was 73%. Of course, there's wide intervals here, so that's just something to keep in mind. And then with 2 doses, the vaccine effectiveness increases to 69% for preventing COVID-19 infections. And then it's 84% for severe outcomes or hospitalizations and 90% for preventing mortality. As we were discussing before, there seems to be a difference in the antibody response that you get with Moderna in comparison to Pfizer. And what you'll see here is it is interesting that the point estimates for vaccine effectiveness are higher for Moderna than Pfizer, 70% for 1 dose, 83% for 2 doses, and obviously lower for Pfizer. Unfortunately, this is a subgroup analysis, and so the study is not powered to really look at this difference, and they technically overlap with their confidence intervals, so you can't conclude this is significant, but it's perhaps suggestive at the least. And so what we learned from this study is that we concluded that 1 dose of vaccine seems to offer limited protection, some protection, maybe 40 to 50%. And we do have to acknowledge that the majority of the second doses were given as the third wave was fading out. And so because you have less infections in that time period, it might bias you to getting higher numbers for vaccine effectiveness. So that's just a caveat to keep in mind. And so this patient population was also not matched. So there's always some possibility that there's some other confounding that goes on. And so we've always been wondering after, COVID-19 infections, we've learned that you can still get breakthrough infections after 2 doses of vaccine. And the United States has done a good job of asking people to report when people had breakthrough infections who are on dialysis. And in total, what they found is that they've gotten from January to July of 2021, they've reported 1,810 dialysis patients who had breakthrough infections. The majority were really symptomatic, of almost 70%, and 43% were hospitalized, and the mortality was 7.5%. So that's pretty significant still. This is preliminary data, and they've likely collected additional data. They also were just wondering, given that, the variants of concern have changed over time, with Delta variant being the predominant variant from sort of June moving onwards, they compared sort of what the differences were pre-Delta and post-Delta. Hopefully we may have like a pre-Omicron, post-Omicron comparison in the future, but they did find that perhaps more patients were symptomatic when in the Delta, post-Delta period, but the hospitalizations and mortality are similar, but it's still pretty significant. 42% hospitalization with a breakthrough infection is still quite concerning in the dialysis patient population. We have been fortunate that in Ontario, at least, we haven't really had much outbreaks since the vaccination has been instituted. And of course, this brings us to boosters, which are rapidly unrolling out in Ontario. And we've been sort of trying to keep up with all the changes in eligibility with boosters. And as of about last week, our dialysis patient population was actually approved for booster vaccination. And most of the evidence from for boosters has come from other countries who have been sort of ahead of the curve, including Israel. And this was a study that was literally just published yesterday in the New England Journal of Medicine that actually really nicely demonstrates that when you get a third dose of Pfizer in adults who are age 50 and above, there's a 90% reduction in mortality in comparison to people who did not receive boosters. So it's really compelling evidence that the boosters are going to be useful. And in our dialysis patients, we don't have as much information yet. There are a couple of countries that, also have been ahead of the curve in giving that third dose to dialysis patient populations. And this is one from France, where it does look like the antibody response does go up dramatically after you get that third dose. So they noted in this study, it's a small group, but the antibody levels for RBD went up 580% after the third dose. So that brings us to our second polling question, if we can pull it up. And do you think that getting a different third dose of the COVID-19 vaccine from the first two doses is going to give you better vaccine effectiveness? So for example, if you got Pfizer for the first two doses, if you get Moderna instead of Pfizer for the third dose, do you think that that's better? And same thing with if you got Moderna originally, should you get Pfizer for your third dose? So we're curious to hear what you think. Interesting. Okay, so 66% of people thought that yes, and then 34% of people have said no. And of course, actually, I don't know the answer to this question yet because we're still wondering at this question as well. And I myself was wondering the same question when we received when I received my booster vaccination. So we are wondering about the answer to this question. Okay, and so there is some evidence about heterologous vaccination that has emerged. So this is information from the UK where they have the ChAdOx1 vaccine. And there was concern about thrombosis with the ChAdOx1 vaccine. And so after some period of time, they did pause the vaccination for ChAdOx1 for the second dose, and they actually switched people to Moderna because of that thrombosis signal. And it looks like you have to realize that ChAdOx1 is not an mRNA vaccine, so there's a caveat there. But the antibody response was better when you get a Moderna, a mix-up with Moderna for your second dose. And there is emerging sort of mix and match data that may suggest that mixing it up is better, but it still remains a not definitively answered question. And so we are wondering the same question in our dialysis patient population, and we are doing a study called Boost Kidney, and we are looking at not only dialysis, but also advanced chronic kidney disease patients. And we're interested in looking at whether mix and match is a good strategy for this population. So we have about 270 people so far, and we're classifying them whether they got Pfizer for their 2 doses originally or Moderna for their 2 doses originally. We're kind of, for cleanness sake, excluding people who already got mix and match. And then they're going to be randomized to get a full dose Moderna 100 micrograms or Pfizer for their third dose of vaccine. And we're hoping that this will provide us some information on whether one should mix and match or not. And so this is work that is underway. Interestingly, while we've been kind of recruiting for this study, we found that our patients have very strong feelings about the vaccine that they've received. And so patients who have declined often have received Pfizer for their first 2 vaccines and trust that vaccine to a great extent and only want to receive Pfizer for their 3rd dose. And so it is interesting that the vaccine loyalty that is developed, and people have been skeptical. Although in other jurisdictions such as British Columbia, people have actually been encouraged to mix and match, but nothing definitive yet. And so that brings us to the end here. The takeaway points that we wanted you to remember going home are that in this study, we found that dialysis patients had a poor antibody response to 1 dose of vaccine. But when we look at vaccine effectiveness as a whole, although it's lower than the general population, vaccine effectiveness after you get 2 doses of vaccine is northwards of 80% in dialysis patients, and they clearly seem to be working. And an interesting consistent finding that's emerging is that Moderna, mRNA 1273, has a better antibody response than Pfizer. And whether that plays out in terms of actual vaccine effectiveness is going to have to be looked at closer. And of course, the booster doses in our chronic kidney disease and dialysis patient population, we're looking closely at this and hoping to learn more answers in the future. And with that, I'd like to acknowledge the large number of people who have helped make this work possible at Sunnybrook, Mount Sinai Hospital, Unity Health, UHN, and particularly at Public Health. Dr. Shelley Bolotna and Vanessa Tran, who's helping us moderate, have really been invaluable in helping us appropriately design studies to answer these questions. And with that, I'll leave it there and open it up to further discussion and questions. And I do see that there's a number that have popped up.
There was a few that were easy to answer that I could just type a response to. Yeah. And then I think some of them are just comments, Vanessa, that maybe you just want to share with the group because they're really important. They're important comments.
Yes, absolutely. So firstly, thank you, Michelle and Kevin, for that very excellent and informative presentation. We have very excellent questions and comments. If you haven't had a chance to do so, please continue to enter your questions in the Q&A pod and we'll continue to monitor them. Yes, I'll just go through the list. So I know, Kevin, you went over briefly the axes of the graphs describing how the antibodies are measured. Can you just provide just a brief explanation of the relative ratio and what that means?
Yeah, we found that this term throws everyone off, including ourselves, but it's actually, so the lab that we use, which is at Mount Sinai Hospital, they have a standard that they've created. And so they can, of how high the antibody response are. And so it's not actually a ratio, it's kind of a unitless value. So, but it probably will be simpler when we convert all these to like the international units.
Yeah, and just and for those that aren't aware, the BAU is the international unit that's been developed by the WHO to try to help with some of the standardization across serology platforms. Okay, we have a very important comment that somebody put into the chat regarding the differences between vaccines. So, you know, it's not just always about mRNA quantity and interval, but there's also other things to consider, including non-coding regions of the RNA, how it's developed, so the lipid nanoparticle, how much of the double-stranded RNA is present in the vaccine. And this person pointed out that in the Pfizer phase 1 dose studies, sorry, the Pfizer phase 1 studies showed that higher doses don't necessarily lead to higher immunogenicity. So it's not always comparing apples to apples.
Yeah, and I think that's an important point as well, because there's so many unknowns. Like we really have no idea why we might have found the results we found in the dialysis population. And of course, we are going to be moving on to do viral neutralization studies because we really don't know anything about how our population will react with the various variants that are out there. And certainly more is coming out from Pfizer saying they're going to be good for Omicron than we've heard from Moderna. So who knows where the future is taking us. So I think that's a really important point.
Mm-hmm. For the vaccine effectiveness studies, can you just clarify that the 2-dose estimate, were the vaccines given at the recommended manufacturer intervals or the delayed interval?
So it probably would have varied quite a bit across the province. So you know, you have to remember dialysis populations are made up of different populations. So you have plenty of people in dialysis populations that are part of the long-term care population that would have gotten it on interval at time. Then you had changes in public health as we were going on. So there was a bunch of them that got it on time at Sunnybrook, and then all of a sudden the rules changed and they extended the interval. And then dialysis is also just a really complicated place to do things where people are always being admitted and sick. So there's probably going to be some variability, but there was a good chunk of the province that would have been done as manufacturer guideline. Then there would have been some of the province that would have been extended. You know, I think they're trying to look at correcting for the interval in that. Now, that whole study that we showed you from ICSS and the epidemiological side of our study, it's also impacted by the fact that a lot of that study was done during the time there wasn't as high of rates of, you know, sort of COVID in the population as well, as you can see, because it went through the various time points. So there will be a variability in the dialysis population just based on what's been happening.
Someone just had a comment about the poll, which I think is a good point to remember when we're talking about vaccine effectiveness. So there's different measures of vaccine effectiveness, either, you know, against symptomatic infection or severe outcomes. So that's a great point. Thank you for that. Shelley has a question. So recognizing that the hemodialysis patients are already high risk, have you observed any additional risk factors for infection? And have you been able to look at infection by race or other social demographic factors?
Sure, I can answer that question. I think in Dr. Oliver's study in CMAJ, it's clear that sort of there's different socio-demographic factors, and race do affect your risk of getting infection. So race is definitely, non-Caucasian race is definitely a risk factor for infection, and it's sort of different geographic clusterings as well. Lower income quintiles were at higher risk. We haven't really looked at the infections, but you know, even anecdotally, when during the waves of COVID-19 in our ICU, when we were rounding on all the patients who had COVID-19, almost all the patients we were seeing were non-Caucasian patients. But that has also been shown in the demographics in the ICES study as well.
And I think there's no question the usual suspects will come out. Age, you know, that's going to come out. We are studying a large population of CKD patients. Many of them are on immunosuppressive drugs. So very much like our transplant populations that have done particularly poorly during this pandemic, that's going to be a factor. I think a factor is going to be GFR itself. I think that we're going to see that what is the level of your ability to clear might be an independent factor. That hasn't really been looked at yet because we don't have large studies as yet, just where we could look at that in just the CKD population, but we're building that cohort as well.
I think someone had a question and follow up to the technical question regarding the assay. Do you know what standard that the Gingras lab compared their relative ratio to?
Yeah, it's actually a synthetic standard, so that they have generated a calibration curve. So it's not actually in reference to the convalescent serum per se. So they've generated a synthetic standard that they can calibrate the levels to. Hopefully that helps answer it a little better, but it still does confuse people, I recognize.
Yes, and every assay is slightly different. So yeah, definitely something to keep track of. So another wonderful question about the cellular immune response, which we know is important, and still lots of research going into looking at the cellular immune response in COVID. So wondering if you could speculate on whether there will be a difference in cellular immunity in vaccinated dialysis patients, and if this is something you'll continue to look at in the future.
Yeah, so we are looking at it. We don't know. So we're collecting samples for PBMCs that are being sort of analyzed now to have better understanding of what's going on with cellular immunity. I do suspect there'll be differences in cellular immunity, whether they'll correlate completely well with the antibody response. I don't think we know that yet, or they might just cluster around other factors like age and lack of immunosuppression and so forth. So we'll have to do the studies, but I think I agree that it's a really important line of study that we're going to have to move into.
Mm-hmm. And your neutralization, upcoming neutralization assays will be very informative as well.
Yeah.
I think just a follow-up question about the mix and match vaccinations. I think, Kevin, you showed a slide showing some data. would you like to just reiterate some of the data that we know about?
Yeah, so there have been like a number, I think most of them are still in the preprint stage. There was like a particularly nice one that had like many variations of mix and match. And they did show that the antibody levels and neutralizing antibody levels did seem to be higher for the mix and match. And so there does seem to be some support for it. I don't think that studies have been able to they show antibody levels, which is a surrogate outcome, but whether that translates into vaccine effectiveness, I don't think we know the answer to that one.
Yeah, and certainly there's many ongoing clinical studies trying to look at that question exactly. Let's talk about boosters a little bit. I know you mentioned that the dialysis patients got added to the priority booster population last week. So the booster recommendation for Moderna is half of that you're using in your clinical trial. And, based on the fact that we know that the hemodialysis patients, do not produce as an immunogenic response, do you foresee any issues with this dose?
Yeah, so just to be clear though, the recommended dose in the dialysis population is not half dose booster, where it's a third dose in the dialysis. So if the Ontario guidelines have not suggested a boost, it's an important distinction because everybody else is getting a boost, and then there's the populations that are eligible for a third dose. So like the immunosuppressed population, like the transplant population, the dialysis populations will all be getting full dose Moderna. Whether that's appropriate or not, nobody knows, but they were categorized instead into like a third dose as opposed to a boost.
Thank you for that clarification. Yeah, I read through that guess way too quickly and didn't pick up on that.
Well, we didn't pick it up either because we thought it was going to really mess up our trials. We got very nervous. And then we looked at it's like, oh, it's still the same for the dialysis population. We didn't know if we had to add a fourth arm of the trial yet. But that'll also be interesting because I don't know, I'm sure there's some data emerging, but is that half dose going to be okay in all these variable populations that it will be used in, as opposed to another full dose Moderna? That'll be a whole area we need to understand as well.
Mm-hmm. Yeah, very much looking forward to the results of your study. Since we're talking about booster doses, I don't know if you wanted to speculate on, based on what we know so far, whether or not a fourth dose would be something to consider in this patient population.
Yeah, we've already started. I mean, Kevin emailed me in the middle of the night the other day. I was like, oh, come on, Kevin, I can't take it anymore. I'm getting old. But no, I think this is there's no question that the longer this goes on, the more we're going to need to keep boosting these at-risk populations because they wane quicker than, they know we're waning. We're all the normal controls in the study. We all know our immunity, we're waning at 6 months, but they're waning more quickly. So, whether we're going to have to keep them on a more regimented schedule of boosts that are even just shy of these 6 month marks, I totally think we're probably going to be facing a fourth booster unless we manage to do a better job on the global stage, quite frankly.
Yeah, they've been trying them in some of the transplant patients in the United States in sort of series. So some of the transplant patients particularly don't respond even worse than dialysis patients. And so they've been trying in people who don't seroconvert after 3 doses, a fourth dose, with a little bit of success, but I guess it also depends on the variants. And I think they're even trying the monoclonal antibodies, long-acting monoclonal antibodies in some of the transplant patients who don't respond to 4 doses of vaccine. So it's really going pretty far.
Yeah. And that's something to consider that we've talked about even dialysis, because there's definitely a cluster in there that's not responding. We certainly have them in the CKD population, the immunosuppressed, that we've given multiple doses, we've given boosts, and there's nothing responding. And maybe that could guide, maybe more broad serology, once we understand more about it, could guide, because they're a rare thing too, is the antibodies, right? To give monoclonal antibodies to actually help fight infection for people that then succumb could be, a really important tool for these patient populations that just can't mount appropriate immunity.
Yeah, that's
lots to learn yet.
Oh, definitely. Somebody had just brought up the option for monoclonal antibody as a pre-exposure, and also, I guess for post-exposure. I think I saw some of the newest data with the Regeneron one. So the combo monoclonal antibody, for the Omicron, it doesn't seem like it is as effective, but the other one, which I can never pronounce, the ones that are in S, sotorafimab, seems to still be effective. So I think this is going to be a constant fight.
We did already figure out that it can be given on dialysis. We've done the homework, so we know this. We know that if it comes and we need to use it, we do know how to give it on dialysis. So that dialysis is an easy way for us to infuse things as well. So there is a possibility that that could be, an opportunity for at-risk people who just don't mount immunity, and maybe boosters by the fourth dose or whatever, where there'll be more widespread understanding of the serological levels. So it could be targeted. I don't know. We'll have to see how it plays out.
Speaking of non-responders, is there anything that we can learn from the hepatitis B non-responders that could be applied to this COVID-19 vaccination?
Yeah, we don't know yet. We sort of thought maybe that would be something that would be one of the things that came out as a predictor, because we did look at sort of the hepatitis non-responders. Are they the same people? But it's not, I don't think we have a big enough sample to know that for sure yet, but at least preliminarily, it didn't seem to be one of our predictors of sort of non-response in the COVID. Kevin, any thoughts? I think we might be just hampered though a bit by number, and as we get the cohort larger, then perhaps we can look more at that.
Yeah, agreed. Like what we've looked at so far in the group of patients we've had, it really didn't come out, even though we keep looking at it because we think intuitively it makes sense. There've been like a couple studies that have found it as predictor, but it seems like nothing consistent. So maybe it's just a bit different.
Yeah, and I guess it would be like along the same lines. I know you only had a couple of infections post-vaccination in your study population. Like, I'm assuming it was too small to look at any potential predictors or risks or antibody levels associated with those cases.
Yeah, exactly. We were interested in those people who had infection after 2 doses of vaccine, because the hypothesis was always that maybe these are the patients that have low antibody levels and that's why they were infected. But actually, I think we didn't have full information on all the patients, but some of the patients who did get breakthrough infections, they actually had levels above the convalescent level. But there have been some other preprints in dialysis populations where I think they had, somewhere between 22 and 37 breakthrough cases. And the people who had breakthrough cases did have lower antibody levels. So it could be that our sample is just way too small to look at it properly yet.
And yet also you have to look at also then the severity. Certainly we're going to still get breakthrough cases, but if they're not severely ill, which, studies show 60% of dialysis patients need to be hospitalized. So, I think as we build this data from around the world, we'll get a better sense.
That's a very good point.
And I will just take this very small opportunity to plug my public service announcement and reinforce that this is why we can't use antibody measurement at this point as a correlate of immunity, because as you see, it doesn't always correlate how we expect it to. Okay, well, I think those were all the questions. If there aren't additional questions or any more points, Kevin or Michelle, you wanted to bring up for discussion?
No, we're just thank you very much for having us. It was great to be here today, and we learn as much from you guys as you might from us, because like I said, we're not experts in this field at all, but we're certainly trying.
One of the blessings or silver linings of the pandemic is bringing groups together that normally wouldn't have a chance to interact. So thank you so much again, Kevin, Michelle, for the wonderful presentation. So as we wrap up today's PHO round session, I would just like again to thank our speakers for presenting. I would also like to thank everyone who joined us for today's session. It's so great to see such strong virtual participation at such a challenging time for healthcare professionals and everyone. You can expect to receive a brief and anonymous PHO round surveys for today's session. I really encourage you to try to please complete these, as it really helps us to improve our programming moving forward. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. So thank you everyone again. I hope you have a fantastic rest of the day.